Welcome, everyone, to WADEM's next in the series of COVID-19 podcasts. This podcast is on disaster telehealth, and we are fortunate to have Dr. Richard Bakalar, the Vice President and Chief Strategy Officer of VitalNet. Dr. Bakalar has over 37 years of clinical, telehealth, and medical informatics and healthcare executive leadership experience. He's a former captain in the U.S. Navy, where he was the Navy Surgeon General's first special assistant for telemedicine. He's also the former president of the American Telemedicine Association and was a chief medical officer on IBM's Healthcare Solutions team. Dr. Bakalar, thank you very much for spending time with us today. May I ask you, can you tell us a bit about the evolution of telehealth and its role in global healthcare today?
Well, Greg, thank you. This is an interesting topic because, and very timely topic, obviously, in the setting of the COVID-19 pandemic. Ironically, telemedicine was conceptually started in about 1924 when U.S. Radio News published its conceptual illustration of the radio doctor. And at that time, it was a patient, a pediatric patient under examination on a radio, and a doctor illustration. The same year in Germany, there was an illustration by Dr. Franz Kahn, who illustrated the biometric data on a wall-mounted unit with X-rays and waveforms. But that was just a conceptual use of what we know today as telemedicine. Fast forward about 50 years, and in 1968, telemedicine was initiated, and the term was coined by Dr. Ken Bird and Mass General Hospital in Boston, where the doctor wanted to be able to evaluate patients at Logan Airport remotely from his office in downtown Boston. The concepts of this was all about bringing the patient to the doctor and trying to be able to provide specialty services or elevated care to the patient when they had underserved populations, either in this case the airport, or nowadays in remote locations or underserved populations. This has progressed, and I want to talk about it in terms of domains. So I'll start with the clinical domain first. And we think about telemedicine in the clinical domain, we think about the fact that, as I said, when this became more practical from a technology perspective, exceptional specialty care for underserved populations was the priority. And then also there was contingency care for disasters, for acute injuries or illnesses. In that situation, there was a focus on triage, stabilization, telementoring, or transport for those patients that needed to be moved to a higher level of care. Later, in the 1990s and early 2000 timeframe, we started adding remote patient monitoring for chronic conditions as internet technology and mobile devices became more available. Finally, primary care, remote urgent care became feasible, and employers and payers found this to be important to help their employees get care on a more regular basis in a more convenient format. Now fast forward to 2020, COVID-19 pandemic. Actually, this is a major shift because now the goal is to bring the health system to the patient as opposed to the other way around. And the idea here is because of the concerns over patient safety, community safety, and healthcare, but health worker safety, the idea is to be able to use technology to bring information and best advice to the patient where they are, as opposed to bringing the patient to the health system. So the idea here is you want to be able to use technology to move information and not people, as the Navy Surgeon General said in about 1995. But the important point is that today, we have an issue with the fact that many people were not prepared to scale telemedicine to the level at which it's needed for today's pandemic. And in the military, we have a phrase that says, train as you fight and fight as you train. There needs to be advanced preparation and experience in the routine care of new care models in order to get most effective use. So what are the technologies that have evolved over the last 50 years since the term telemedicine was coined by Ken Bird? Well, first and foremost, let's talk about the computer hardware. In the old days, in the 1990s, we used actually video cameras from TV studios to provide telemedicine or teleconsultations using video signals from one point to another using a line-of-sight communication. Later, there were multi-purpose mobile devices such as tablets and phones, which has made it much more feasible. Second, the peripheral medical devices have become much more widely available. And initially, they were standalone wired, and now they're integrated using wireless Bluetooth communication. Telecommunication has improved with moving from dedicated circuits to now secure internet protocols for broadband and cellular communications for backup. Software has shifted from being dedicated silo applications with data pools that were isolated from the health information systems to more modular platforms that now can be integrated with the electronic health record and other health IT systems. And finally, over the last 10 or 15 years or so, standards have evolved, such as HL7, DICOM, Internet protocols, and a new ICE standard, standard that allows for interoperability between health systems. So this technical domain has really jump-started a lot of the opportunities to use telemedicine that we know and use today. Now, from a programmatic perspective, this is where the real challenges have been, because the technology is much more advanced today. But we've moved from a situation where most organizations have small projects for a single department in which they use either grants or pilot funding to start a project, but really never scaled it to anything like we're seeing today. For example, a recent survey has shown that over 48% of physicians in the COVID-19 environment are starting to use telemedicine, whereas only 2 years ago, that number was closer to 18 by the same survey. Proof of concept pilots need to be scalable and sustainable. In order to accomplish that, there needs to be the discipline around a program, which includes funding, alternative reimbursement models, sustainability. There needs to be support, training, and communication plans. So for all of these reasons, we're seeing now a very rapid increase in the use of telemedicine. The only concern I have as I watch this recent growth because of the recent pandemic is the fact that most people are considering video calls as telemedicine. As we'll talk about in a few moments, that's really an underestimation of how telemedicine can really impact the healthcare systems and improve the delivery of care, even for routine care as well as during a crisis or a disaster.
Well, thank you. Thank you. That's some very interesting stuff. I actually didn't realize what a long and rich history telehealth had, and it dated back so far. So tell me, what are the critical success factors when developing a telehealth program, and how should you start if you're interested in developing one?
Well, thank you. Well, once again, I think it's important to break it down a little bit, as I talked about before, starting with the clinical considerations, because all programs that are successful and are widely adopted start with a clinical need, and there has to be a medical purpose to a program or a project in order for it to be successful. So a needs assessment, which includes what's included in the project or program and what should be excluded. For example, chest pain and things that need immediate attention by a local healthcare provider should not delay care for those patients. For things that can be treated remotely, those are the things you want to emphasize in your program design and selection. The other is the idea of what are the appropriate encounters for telehealth based on the telecommunications availability, based on the availability of treatment options, based on the ability to maintain that patient in where they're located, whether they're on a ship in the case of the U.S. Navy, or in a field hospital, or in a remote civilian facility, or even in a gymnasium, as we're seeing today, where oftentimes in a COVID environment, we have to create alternate care locations, similar to what a field hospital might be in the military. The other concept is the idea of making sure that there's a trusted provider to provider relationship. We call it professional bonding. In order for a remote primary care physician or nurse practitioner to trust the advice they're getting from a remote consultant, there has to be a trust factor. And oftentimes we use education to be able to initiate that bonding, that professional bonding and trust that's needed for ongoing clinical consultations. The other is the idea of workflows that need to be considered, and they should be as close to how providers provide care in the face-to-face world in the virtual world. And in some cases, it'll be on demand. In other cases, it'll be scheduled. And scheduled visits are always much more efficient when the time is not much of an issue. So we try to limit the on-demand consults to those that are required for specific time-sensitive decision-making. And finally, the other clinical consideration is the idea of having a standardized practice guidelines and protocols. And a lot of the organizations, such as the American Telemedicine Associations and other international bodies, have published practice guidelines to help organizations starting out to define what those protocols and guidelines might look like. From a technology perspective, the idea is to pick technologies that are very similar to what's in place. So, for example, a lot of the medical devices and hardware, you should try to leverage what's already in place and not try to change or replace those unless absolutely necessary. The other is to keep it as simple as possible and not try to make it more complex, and try to address the problems that are being addressed and use technologies that will support those, and not add a lot of complexity that requires more training and more sustainment and support than is necessary. The other is the idea is confirm that the hardware is needs-based based on the service lines that are being selected. And oftentimes you start with a very general capability and can go to specific service lines when there is a high enough volume to justify that change, or there's enough of a volume of those kinds of patients that require a more detailed analysis or a more specialized consultant. And of course, patient privacy and network security are very critical considerations, particularly internationally. Although in the U.S. we have the HIPAA rules and requirements, and other countries are very serious patient privacy considerations that must be met in order to apply these new delivery models. And finally, the idea of documentation. When I was in nuclear medicine and an imaging physician, I learned very early that 51% of an encounter is based on the documentation of that image, not the image itself. Because if you don't have documentation, you don't get reimbursed, and it's not considered a effective evaluation. And so the documentation in a telehealth consult is very important, and the information needs to reside in the system of record at the end of an encounter. And that's one of the challenges we have today, where a lot of organizations are simply using video calls to conduct a teleconsultation or a telehealth consultation, and there's very limited or no documentation, or the documentation in the EHR may be scant and may be incomplete with respect to other information that might be important for follow-up in the future. So the clinical documentation is very important and should be part of any telehealth platform that's provided to a system. And then finally, I always like to look at user training and support because if there's not good training for the providers, adoption will be either delayed or ignored. And therefore, it has to be considered at the beginning of the program design, not necessarily after everything has gone live, for example. There has to be a dedicated communication path, either a phone line or an email address. There should be support for clinicians with low usage so that they can continue to be familiar with the technology. And that's one of the challenges we face today as we go to a threefold increase in use of telemedicine in the United States, for example, during this COVID pandemic. Many of the providers had little or no experience in using telehealth until now, and so they've abandoned the more robust capabilities of the systems that are available and have resorted back to a telephone or even just a simple video call on a system that may not be as robust as what's possible. And of course, the importance of a help desk, and I think of a help desk in both the clinical domain with a clinical navigator to help clinicians make a decision of what the appropriate resource might be, and a technical domain where there's a help desk for technical problems both locally and remotely as needed. And then finally, I think it's important to look at measuring your performance with metrics and KPIs or key performance indicators. This is important for accountability of programs, but it's also important for quality assurance, operational efficiency, and to ensure that there's a good return on investment for any program that's being initiated or sustained. And of course, because it's a clinical service we're talking about, there needs to be quality assurance and peer review, just like any other practice in the face-to-face world in a hospital. So those are some of the key issues that we find when programs are being established, and when they're shortcutted, oftentimes the adoption is compromised.
Well, that's some very interesting stuff, Richard, and you know, you can see that a lot of effort has been put into all these different factors around telemedicine, and really making it so that it integrates, seamlessly into the healthcare system. I can see now why telehealth is becoming, so well integrated into so many different systems around the country, around the world. And also, I can see now why we so quickly looked to it during this pandemic and started to implement these systems, even if some of them were started from scratch. So along those lines, where and how do you see disaster telehealth providing solutions in this COVID-19 pandemic?
Well, COVID pandemic, I think, is a great illustration of how it's important to think about telemedicine not as a single episode of care, but rather across the continuum of care for an infectious disease. And I think it's real important to think of it in those terms, because today we're concerned about the pandemic of COVID-19, maybe this year and next year, but beyond that, there's going to be other infectious diseases or other crises that involve healthcare that should be considered across this continuum. But specific to COVID-19, one of the things we look at is using a platform that crosses this continuum of care, and I'll divide it up into 5 different tiers. The first tier is the teletriage, where the patient is typically at home or in a remote location and engages a health system to be evaluated to determine if they're a COVID risk patient or if they're a patient that is not a COVID patient but may require routine primary care or urgent care or chronic care as follow-up, but not necessarily be in quarantine or isolation. And that's an important, and we call that tier 0. The tier 1 being the triage tier. And then when those patients are identified as being heavily exposed to a COVID virus patient or asymptomatic and not tested yet and needs to be evaluated for testing, or maybe post-test positive and need to be in quarantine to assure that they go back to negative status, that's our tier 2. Those patients should be watched carefully because they can deteriorate rapidly and require a higher tier of care going forward. And we don't want to miss the opportunity to be able to preemptively treat those patients aggressively if they need that. The tier 3 are the patients that are in isolation, either at home or in a residential facility, in a skilled nursing facility, for example, in the case of seniors, where they test positive and have mild symptoms and don't need to necessarily be, quote-unquote, hospitalized or put into an acute care setting, but need to be watched very closely because of the rapid deterioration of physiologic parameters, particularly around pneumonias and other secondary effects of the COVID virus that we've identified. And then, of course, tier 4 is the telecritical care inpatient scenario, where we want to look at patients who are in a critical care ICU setting, may need to restrict access to that patient because of concerns over exposures of healthcare workers, and you may want to use telehealth or telemedicine tools so that minimal inpatient or in-room access would be required, and many of the clinicians can be evaluating the patient outside the room, or you may want to have a remote specialist and be able to monitor them there. So we have that entire continuum, and one of the things in our case of our telehealth platform at VitalNet is we support the entire continuum of care for evaluation by collaboration, by video conferencing or chat, by imaging, medical imaging, sharing radiologic images or EKGs or other visible light images, and the ability to be able to evaluate patients on an ongoing basis when they transition from one tier to the next, so that there's good continuity of care. And we also have what we call a population manager that allows you to evaluate patients for follow-up care so they can self-report. And those that need to be transitioned from one tier to another are done efficiently, and patients don't slip through the cracks, so to speak, and are lost to follow-up. And that's the biggest concern. We've seen in New York, for example, many patients have died at home because they weren't adequately followed or didn't even know that they had the disease and weren't adequately monitored and followed. So having this kind of continuity of care approach is very important for the safety of the patients, safety of the healthcare workers, and the community to enforce quarantine, isolation, and then acute care when necessary in a patient setting.
Yeah, interesting. WADEM members, they span the globe, of course, and most, if not all, are fully engaged in this pandemic right now, this crisis. So they're either in the the preparedness phase where they haven't quite gotten the surge yet, but they're preparing, or they're fully engaged in the response. And I'm sure that all are either actively using telehealth systems that perhaps are already in place, or perhaps adding on new solutions to an existing telehealth system that they have, or perhaps thinking about a telehealth solution, but they don't have any right now. So, given all that, do you have any advice for those of our members and others listening to this podcast who are trying to apply new telehealth solutions for this crisis?
Well, actually, the first message I would give to all, and having lived it myself, setting up the U.S. Navy's program in the 1990s, is try to keep the solution as simple as possible, as long as possible. The biggest challenge is to try to, what we call, boil the ocean, or do everything for everyone at the beginning, and nothing gets accomplished and very little gets adopted. So keeping the solution simple, low complexity, using existing workflows, using existing technology where possible, and only inserting software which is highly scalable and efficient and can be adapted to new workflows as we learn new things. For example, in COVID world, there's oftentimes new symptoms we're learning, new secondary complications of the disease that can be rapidly inserted into a server-based, cloud-based solution, and therefore be a much more scalable solution than particularly a fixed application that may be hardwired into a medical appliance or a medical device, for example. So having cloud-based solutions, using existing peripheral medical devices when possible, using existing workflows when possible, and ensure what I call the form should follow the function. So always start with what the issues and problems are and make your solutions appropriate for that context, and not try to do things that are inappropriate. And finally, measure. So KPIs, measure your progress. If things are going better, continue doing it or do it better. If things are getting worse, maybe we'll resort back to a previous stage of design because maybe what you're doing is not going in the right direction. So continually measuring and getting that feedback loop is very important for effective delivery of telehealth and telemedicine services. And then finally, from a financial perspective, make sure the incentives are aligned with the goals and the projects of the project. And oftentimes in the fee-for-service model in the United States, for example, there's misalignment of incentives, and telemedicine has been deprioritized here, for example, because it was removing some of the incentives for the face-to-face care. Now, when face-to-face care is not practical or desired, most health systems aren't prepared now to move to that new delivery model. So we want to have outcome-based incentives as opposed to service-level incentives, if possible, to get the best adoption and the best investments in the workflows that are going to be most effective going forward.
That's great. That's great. And I guess a final question I have for you is, I've been observing last few months during this crisis, all the new telehealth solutions that are being stood up, and there's in hospital telehealth solutions, internal to the hospital. There's other solutions that are being stood up that allows primary care physicians to see patients and care for patients in their home or perhaps in a long-term care facility. All these new telehealth solutions are sort of being developed and utilized during the crisis. Do you think some or all of the telehealth solutions that are newly created now will continue?
Well, that's a great question, and I think the challenge there is it's kind of like 9/11 in the United States, where pre 9/11 airports had easy access by all guests and patrons of the airport. But today, security has markedly changed ever since 9/11. It was kind of a step function that occurred during that time frame. I think telehealth is going to have a similar growth spurt now, in which business models and regulatory changes are going to be plentiful after the dust settles from the COVID-19 pandemic, or at least the acute and secondary acute phase, probably late next year. So I think there'll be new business models, new regulatory changes that will expand and be more favorable to adopting telehealth in the future in what we call the post-COVID-19 new telehealth normal. I think patients and providers will embrace it. Patients have embraced it for a long time, but providers have been hesitant because they've been very busy doing face-to-face care and really haven't taken the advantage of some of the workflows that could be more efficient than a direct patient in the clinic experience. So I think the combination of patients and providers using it on a regular basis at least for the last 2 months, will be a driver for them to look for new opportunities to adopt it and integrate it into their workflow. But I think the key word there is integrate. I think to be able to do it as a standalone for the large percentage of the population, and when I say large, I mean over the tipping point of about 20-25%, I think is going to require more integration of information systems, more integration of workflows, and more integration of payment models that are more friendly to taking advantage of some of these new delivery models. The idea of shifting from video-only applications to more of a modular platform, I think, is going to be important for connected care. As I mentioned, we want to provide a continuum of care for patients, not simply an urgent care, single episode of care, which is what typically most people have thought about telemedicine and telehealth for the last several years, at least in the United States. And I think that's particularly true in a disaster environment because of the fact that patients are going to potentially be moved or medevaced from one location to another, or one tier of care to another. And when that happens, there needs to be continuity of information, continuity of records from one level to another. And the records need to be stored in the systems of record, not in a cache in a single application. So an app store approach to telehealth is not a good model. It needs to be much more of an integrated capability that needs to be developed and invested in by health systems going forward. And the other, I think, is the importance of sustainable accountability. And in order to do that, there has to be measurements. And we start out with descriptive analytics, but I think we'll move to predictive analytics going forward. And I think that's going to be very important as we take advantage of some of these new delivery models. So the capability of using artificial intelligence and automated decision support will be increasingly important in the future of telehealth solutions.
Well, thank you so much, Dr. Bakalar. You provided us with a wealth of information. I think our listeners are going to really enjoy hearing that all the different information that you've given them, and we'll be able to put a lot of it to use. So we really very much appreciate it, and thank you so much for your time.
Absolutely. Thank you very much for the opportunity.